So I'll just talk to you about third nerve palsy, something which we've been doing for a very, very long time, and we still have a long way to go before we can actually come out with anything that can help these patients. But third nerve management can be quite difficult. Dr. Ankur showed this case, herpes zoster patient so the important thing is that you need to identify whenever you have an acute palsy. We haven't discussed early management of these cases, but whenever you have a patient presenting with an acute nerve palsy, you need to treat it like a stroke unless you are suspecting that there is some space-occupying lesion. So think of a space-occupying lesion, clinically or by investigation, rule it out. If you think it is an ischemic or a mononeuropathy, then you can follow up and just make sure that over time the patient is following up and does not progress and tends to get better. So, of course, you have to rule out and then wait for a while. I would say at least 4 to 6 months before we plan surgical intervention in any of these cases, whether it's a fourth, third, or a sixth nerve palsy, and only plan after you're sure and the deviation has stabilized. So whatever improvement had to be occurs, and then subsequently you plan for surgery. So in this case, we were not sure what is the cause, and then those few lesions of herpes zoster we realized could possibly be responsible. We closely followed up this patient and he was okay. So again, medical causes may show spontaneous recovery. Just follow up these patients. But now, actually, surgical management of these cases. So what are the options that we have? So you have a recess resect procedure. It has been mentioned for sixth nerve also, same for third nerve. If you have some function of the medial rectus and the eye is crossing the midline, you could think of large resection procedure, either of the same eye or of the other eye. We'll see the advantages of doing the other eye procedure. The other alternatives is a lateral rectus periosteal anchor with a large medial rectus resection. Again, this works if you have some strength. It's like, flogging a dead horse. If your medial rectus has no function, as much resection as you want to do, you can do, but over time it will just go back because there is no tonus in the muscle. It's just like a cord. You're tightening up a rope and the stretch or the tendency for exo will pull it back again. So if there is some function, you can think of doing a large MR resection. And for those complete third nerve palsies, we generally have an alternative of a globe anchor to the medial orbital wall with a large, with a lateral rectus recession and a lateral rectus transposition to the medial side. So incomplete third nerves, resection procedure, involved eye, contralateral eye. Here you can see that there is a significant amount of adduction. You can see that the eye is able to adduct, so we would go for a large recess resect procedure. That would help us to remain in the do a physiological surgery and still get the advantage of adduction and abduction. So you don't have a fixed globe which you would have by any of the other procedures. Here you can see this patient, we were talking about the other eye involvement. You can see that this is a third nerve palsy patient. You have the abduction in primary gaze, you have the ptosis. On adduction, you can see that the ptosis gets corrected because of aberrant innervation to the LPS. So this is something that you can take advantage of by operating the other eye. Operating this eye does not change the innervations. So you have a third nerve, you have two places where you can intervene. The operation on the opposite eye, which is the fixing eye, changes the innervation to all the muscles. And that is why post-operatively when we did the left eye, you can see that the ptosis also gets corrected along with the deviation. So innervational changes are occurring when you are operating the fixing eye. Whereas if we had operated this eye, we hope we would have got as good a correction, but the ptosis would have remained because there would have been no change in the innervation. So the LPS would not have got any additional innervation. Ptosis would have remained. So if you have aberrant innervation, see if you can take advantage of that. So we'll talk about the lateral rectus anchoring to the periosteum. Yesterday we had the VAST where we had shown the videos. So I won't show the video, but I'll just again tell you, you can see that there is some adduction here. You have a third nerve palsy, you have some adduction. You can see the correction in primary gaze is pretty good. The importance is that there has to be some function of the medial rectus. So here we did a lateral rectus periosteal fixation along with the medial rectus resection. So it is advantageous if you have some medial rectus function. But when we had a case of a complete third nerve palsy where you can see that there is virtually no adduction, there is almost no change from primary gaze to levoversion, here we found that this thing did not work so well. So you have a pretty large residual exo in such a case. So what would you do when you have a complete third nerve palsy and you don't have any adduction that you can possibly make use of? So the two things which we have been doing, initially we've been doing for a very long time, glow fixation to the medial orbital wall. We had various kinds of approaches. The DCR approach, we use now the precurruncular approach because it is neater and does not lead to significant scarring on the skin. And of course, the lateral rectus to medial rectus transposition. So just a bit on the medial wall periosteal anchor, we open up the area just medial to the caruncle. So between the skin and the conjunctiva, just medial to the caruncle, we open it, we go straight back. It's a potential space. The moment you open it, you reach the periosteum, you pass your sutures through it. Here on the medial rectus is exposed just like you would by a conventional limbal incision. You bring out the sutures onto the medial rectus and you tie them. So that's what, this is a large lateral rectus we are showing. You need to free the FDT. So in any paralytic squint, the most important thing is that the FDT should be free. So a conjunctival recession along with freeing the FDT was important. Then this is, of course, we have exposed the medial rectus and just left that. Here we can see we are opening up this. We've held the caruncle, and this is the skin, and we are opening up into the precuruncular space. The moment you open it, you have this potential space which you can go into. The sac and the lacrimal apparatus is superiorly and is left out and does not get injured unless you are, during the time of manipulation, you injure. So it's through that periosteum you pass your sutures. You have to make sure that they are through the periosteum. Then you make this opening with blunt dissection and bring these sutures out onto the medial rectus, on the sides of the medial rectus. And then you tie them. The important thing in these cases is that you have to intraoperatively leave a slight ezo, because these are sutures onto the periosteum. Over time, there is a little bit of laxity that starts happening, and therefore you overcorrect them ever so slightly, about 10 degree or so intraoperatively, to catch the exodrift that you are going to see over time. So you close the conjunctiva the way you would normally, and you can just pass one suture there. It just opposes there. So this was the case we were talking about. You can see that post-op, you can see a pretty good primary gaze alignment. Again, these procedures give you good primary gaze alignment, but of course would not be very helpful for ocular motility. So if you have good ocular motility, or if you have some medial rectus function, these are not your primary procedures. They are only advantageous in complete third nerve palsies. Another case where we have done the medial wall anchor, over time, like I said, you would see a little exodrift that would occur. So always try and overcorrect ever so slightly so that you are able to catch that drift and get long-term alignment. So all these patients, again, the ptosis does not obviously get corrected, so they use crutch glasses. There is no change in the palpebral fissure. The other thing recently we've been doing, and yesterday we had shown this video of lateral rectus transposition onto the medial side. A very interesting procedure has been there for some time, but Dr. Gokigit's lecture paper here in JAPOS in 2013 really got us interested onto this. So Dr. Sukhija et al. Had written that it is not as effective, and even the paper by Dr. Gokigit had shown that 5 out of 10 of their cases had a residual exotropia. So this is just to show you their procedure. This was the lateral rectus where it was supposed to be inserted. This is the superior view. The lateral rectus has now been shifted onto the medial side, going under the superior rectus and the superior oblique. So this is the superior part of the lateral rectus, and this is the inferior view. This is the inferior part of the lateral rectus. So they were brought medially and sutured here. So this is the way that was described by Gokigit et al. So when we had this patient of third nerve palsy and we thought we should give this surgery a try, that's what we did. So the only addition we did to the whole thing was that we added an augmenting suture to it. So besides shifting this, we actually fixed this posteriorly so that we were able to fix the muscle onto the medial side and augment the force. So one of the possibilities was that you would have an undercorrection. That is why we added a posterior fixation suture to this. So a post-operative alignment, just by doing lateral rectus transposition onto the medial side, we got very good primary gaze alignment. Again, there is a primary gaze alignment. You would expect that there would be some abnormal ocular movements because an attempted adduction abduction, you would have the lateral rectus firing, but we did not see so much significant adduction happening at that time. But it would probably be because the basal tone was the only thing we were making use of. Another patient who was a large third nerve palsy, you can see very good primary gaze alignment. Obviously, you also induce a lateral rectus palsy because now the lateral rectus is not where it was supposed to be. Now, the other modification that we realized we could do in this case was you have this patient with large exotropia and hypertropia. So vertical deviations also are seen in third nerve palsies. Now, just doing a split LR to MR would not probably suffice. So in this case, we took the entire lateral rectus and took it from the inferior root. We did not split it. We took the entire lateral rectus, took it from under the inferior rectus, inferior oblique, and brought it to the medial side. So although we found that the adduction attained or the primary gaze alignment was a little less than what you would in a split transposition, but the vertical correction was pretty good. So if you want to add vertical correction, you could probably not split the muscle. So again, this was a patient with exo with hypo. So here you can see that the eye was down and out, and we used the lateral rectus, shifted the entire muscle from lateral rectus, from under the superior rectus and superior oblique onto the medial side. So again, you can see that the exo is not so well corrected, but you can see a really good improvement as far as vertical correction is concerned. So that's something you can take advantage of. Again, like I said here, we had done it by the inferior root. This was, you can see the hypertropia there. The eye is pretty much under the lid. You cannot see it, so we took the muscle from the inferior root. You can see the exo is still there to a small extent, but we do have fairly good vertical corrections. So to talk about management of third nerve palsy, we have increasing options. The way to work them up is first to decide whether it's a complete third nerve palsy or an incomplete third nerve palsy. Then you look for aberrant regenerations and whether any of these aberrant regenerations can be used to your benefit. Then, of course, if you have aberrant regeneration and you feel you can, sometimes, of course, it's difficult to convince a patient about other eye surgery, but that's something you can do. You can even think of doing large bilateral lateral recti recessions instead of doing a resection in one eye if you are having aberrant regeneration. So the aim is to try and see if we can make use of aberrant regeneration if it exists. And finally, you have to see the amount of deviation and what is the kind of deviation you are correcting. All these surgeries exist, all of them have their limitations, and all of them would be indicated in certain things. So they have a graded response, so you plan your surgical intervention as per the response that you require. So LR to MR, the advantage is that you can possibly correct vertical deviations. The downside is that if the FDT is very tight, it may be difficult to mobilize it onto the medial side, in which case I tend to prefer periosteal anchors. So particularly medial anchor if the FDT is tight, or in cases where previously the patient has been operated for an R&R procedure and there is a large exo. So I would probably think in terms of a medial anchor. Thank you. So